Biased, but you'll see. But I hope to give you sort of pros and irritations too. So welcome. Any Tottenham fans here?
Tottenham.
Tottenham.
No, other side.
Goodness. I won't go any further. Yeah, this is the North London area for those who aren't familiar with the little rivalries. Oh, holy. So, what I'll do is the first talk will be more about how it works, what it measures, and just sort of, for those who are familiar with it, a refresher. For those that you will just go through how it can be used, accuracy, etc., etc. And after your coffee break, I'll make you do some work, do some case studies. They're always fun, aren't they? And then put you on the spot. What do you do next? If you have any questions or I haven't explained anything for your satisfaction, feel free to interrupt. Will absolutely not be insulted or depressed if you go, what do you mean? But feel free. Okay. I think one of the major things, which is one of my beefs about where we're going in medicine at the moment, but from a medical and a nursing point of view, is physiology seems to be forgotten. You know, junior doctors and nurses are seen now to be sat more at the computer monitor than at the bedside. And, you know, a lot of the decision making is sort of empiric rather than guided. And so it pains me, because I grew up loving physiology, to actually see this trend. And I think once these skill sets are lost, you know, being at the patients, looking at them, examining them, talking to them, you know, it'll be hard to regain them. So I think the doctors actually taught me a lot over the years, and you know, every clinician thinks they know what they're doing, and unfortunately, time and again, it showed me that actually I didn't know what I was doing, and it actually helped guide hopefully an appropriate therapy. Okay, this is the Doppler effect. So, okay, you're all familiar with that. You know, police sirens, whatever. They built a motorway in Sweden, and by a housing estate, and they came back after a year to ask the Swedish people, had it made any difference to their lives? And the answer was no. Oh, well, I thought you were funny. Okay, but essentially, that's the principle. Moving on. So essentially, if you send sound waves at a moving object, or the object itself is making those sound waves like a police siren, it bounces off and reflects back with a shift in the frequency, which is proportional to the speed of the moving object. So that's essentially the principle, that the higher the velocity, the movement of that car or whatever, the higher the pitch. And we have the name of this man, Mervyn Doppler, who I think in 1842 first came out with the concept, and it was actually, he was using it to look at the movement of stars and of the galaxy. And allegedly, he put an orchestra on a moving train playing a single note, allegedly, to actually confirm this sort of Doppler effect. And there's his equation. It was that. The computer says no. Yeah, there's the equation, and essentially the important things to measure. There are some constants in there. But the velocity is the v, the frequency shift, that which we hear. So the frequency, the Doppler, the oesphageal Doppler emits is 4 megahertz, which we can't hear. You know, we can hear up to about 20 kilohertz. Big dogs can go higher, but we can't. So it sends out a frequency way above human hearing, but the frequency shift, which bounces back off moving blood corpuscles, we can hear that falls within the audible range, and that's the FD. And the other thing that take into account here is the angle. So the angle between the ultrasound lead and the direction of the moving blood. So there's a cosine of theta. Anyone who remembers maths? Any good mathematicians here? Or no, you're all looking down sheepishly. But essentially, the cosine of 0 is 1, and the cosine of 90 is 0. 90 degrees. So the closer it is to 0 degrees, then it's closer to 1. And so it doesn't make any difference to the angle has no effect. But I'll come back to that point later. Happy so far? Okay. This is the first use of or insertion of an esophageal Doppler probe, and it was done by Simon Gosling. That is Gosley, who became later on the professor of medical physics. Guys, his other claim to fame, practically more so, is he did, I think it was photograph 51. Photograph 51. So Crick and Watson, when they were doing the DNA thing, they came down to London, and there's lady Rosamund Franklin, and they basically got the idea from her work, and he was her postdoc. So, he was the one who actually did the work and came up with the photograph from which the double helix was discovered. So, yeah, not bad claim to fame, but he was also a very good medical physicist, and he first published this as a short report in Nature in 1971, and they put there a probe, and you'll see this is what the signal looked like. It was obviously much more rudimentary than the clever electronics we have now, but you can see a nice waveform, and I'll go into what that waveform means in a second. But there, in 1971, he was able to do it, and this was in man. And obviously, things have evolved, and now you have sort of online measurements and a fancier-looking machine. God, in his wisdom, evolution or whatever, thought, when I create man, woman, whatever, let's have an esophageal Doppler probe in mind. You think I'm joking? But no, it's true. Because, for a number of reasons, the esophagus is bang right next door, and I'll show you a CT scan, an MRI in a second, very close to the descending thoracic aorta. So you get very good signals because of the proximity. Ultrasound travels poorly through air. The esophagus is a collapsed tube, so it helps to hold the probe in place. And the esophagus also sort of secretes mucus, and that mucus acts like ultrasound gel. So it takes a little while, 20, 30 minutes to build up, but essentially that helps maintain a good signal. So you've got this collapsed tube. The esophagus is a collapsible tube. Connects with peristalsis opens up when you're swallowing food. So you've got this collapsed tube secreting mucus, helping the esophageal probe right next to the aorta. And again, God in his wisdom decided about the level of the thoracic vertebra. So it's about 35 to 40 centimeters in a normal sort of height person. They run parallel together. So if you face the angle of the probe at 45 degrees, that you can use as a cosine in the Doppler equation. Easy? Clever, eh? If you're going to design a human body, you design it with a Doppler probe in mind. And the other important fact is that even, and it's been shown in the 1960s, though nothing with Doppler but other studies, that the proportion of blood going to the upper and lower body actually stays fairly fixed despite having a low output or a high output state. It's about 30% goes to the upper body, 70% to the lower body. Obviously, specific circumstances can change when you cross-clamp the aorta. You know, that's an obvious difference. Occasionally with laparoscopy, there will be a bit of a shift. Or if the patient's very sort of head down, Trendelenburg, then you might get some alterations in that proportion. But generally speaking, that proportion 30-70 stays fairly fixed. So the blood flow going down the descending aorta is proportional to total cardiac output. So far, not really great. Okay, and there I promise you some MRI pictures, and there you are. So the thing glinting is the probe, and you can see bang next door to the aorta. And so the other thing I should have added to my list of things, God in his wisdom, when he decided to design the aorta, most of the flow going down the center of the vessel is all traveling at the same velocity, essentially. It slows up at the edges. It's called boundary flow. It was into fluid mechanics. So it slows down with a bit of inverted commas friction at the edges of a vessel, but the flow across the center of the vessel is actually pretty flat. What's called laminar flow. But there's the probe there. So as I mentioned, in a normal height person, it's about 35 to 40. Somebody who's got a lot taller might be 5 centimeters further in, a short ass 5 centimeters further out. So you can obviously, I'll talk about focusing in a minute, but you can gauge, obviously, looking at the patient if they're tall, normal height, or short. And so reiterating one of the things I mentioned before. Okay, so there's a crystal. There's two sorts of D-shaped crystals, one transmitting and one receiving. The frequency shifts, and that's there at the probe, and you get these waveforms. There's a pretty picture. I got it off the Deltex website, and you get the blood being pumped round, and obviously you can see as the blood's going round, the probe there is detecting blood going past the descending thoracic aorta and past the probe. Okay, so what does it mean? So essentially, what the monitor is doing, there's something called fast Fourier transform, which is again sort of physics that translates that whoosh, whoosh, whoosh noise into velocity. And so you have these velocity time waveforms coming up on the monitor. And a bit of physics again, the integral of velocity and time is, physicists here, it's quite a simple one, all mathematicians. Distance. So something going at 10 centimeters a second, in half a second, it'll have gone 5 centimeters. So it's distance. So that's what the area of that waveform represents. And that's a marker of stroke volume. So if you knew the aortic cross-sectional area times distance gives you the volume. But as I mentioned before, this is looking at flow in the descending thoracic aorta, and it's ignoring the 30% that goes to the upper body. However, again, a good thing is that there was basically, it's something I did years ago, but in a whole load of different patients, and comparing it in good old days where we used pulmonary artery catheters, but there's a nomogram. So when you put the probe in a patient, you put in their age, height and weight, and the age is the predominant thing, which basically, as you get older, your aorta dilates with age. It's just a fact of life, I'm afraid. So, but that's your heart's less contractile, and in a way, the dilation of the aorta partially compensates for it. So, if you put in the age, the height, and the weight of the patient, that translates the Doppler value of looking at descending thoracic blood flow into a measure of whole body cardiac outflow. So you don't need to measure aortas, accurately and add to the complexity. The nomogram is actually reasonably good. It is about 90-odd% accurate. Please.
About weight. What's the idea of body weight?
It doesn't really matter. It's a small thing. So, you look at somebody, and dare I say, how good are our weights anyway?
Yeah.
So if it's like 5 kilos out, it doesn't matter. It's just.
And if somebody who's like morbidly obese.
Yeah, I would put the morbidly obese thing because that body is sort of fighting against a morbidly obese body. But I don't think it really matters because if there's again, if I can show you the original data, but there's a small shift with body surface area, but age is by far and away the strongest feature. But thank you, Frank. Obviously, there are a whole number of assumptions. So the ultrasound beam and blood flow, that vector is 45 degrees, the angle between them. That cross-sectional area, so what happens? There's a little bit of a collapse down in diastole, in systole, but that is actually occurring right at the beginning of systole, and it doesn't change. So actually the blood is flowing through a fairly fixed diameter when the blood's flowing through it. That 30-70 split I mentioned, and despite having a drop in cardiac output or a change in blood pressure, that proportion essentially stays the same. So there are a variety of necessary assumptions, but as I mentioned, a whole number of studies, PA catheters being used as near a gold standard as we have, shows it works pretty well. But it's not just the number. Oh, the patient had a cardiac output of 2.5 litres per minute. Well, it's low. Yeah, but what do I do? Do I give fluid, or do I give an inotrome or a vasodilator? So it's nice to have more information rather than just a number, cardiac output. And the shape of that waveform gives you a lot of information about the preload, the afterload, how well that left ventricle is contracting, if there's any flow obstruction, like a pulmonary embolus or mitral stenosis or tension pneumothorax, something like that. And also most of the flow. So you're allowed, especially if you're young, again, going back to physiology, but some of the filling of the left coronary artery occurs in diastole, so you get a bit of reverse flow going into the coronary arteries. So you see the forward flow, those triangles, and you see for a short time at the beginning of diastole in young people, a bit of reverse flow. You tend to lose this when you get old. Sorry, again, to life. But if you see that reverse flow, I'll show you some pictures later, going through the whole length of diastole, that means that patient's got moderate to severe aortic regurg. So again, it's a quick, ready diagnostic. This isn't right, and then get your echo and confirm it. Okay, so there's the waveforms. That's just reminding you the stroke distance is a marker of stroke volume. The mean acceleration is the upstroke, and the peak velocity is the peak. And these are markers of how well that left ventricle is contracting. The flow time is the width of the waveform. The cycle time is the time from the beginning of one waveform to the beginning of the next. And that equates to, on the ECG, the RR interval. And you can use that to correct for heart rate. So just like we correct the flow time, the RR interval and the QT interval on an ECG. So this guy, Fazit, which is still used today in about 1921, came out with a correction factor to correct the QT interval to a heart rate of 60. So it's the QT divided by the square root of the RR. So simply transposing the flow time and the RR interval, the cycle time, that corrects that flow time to a heart rate of 60 beats a minute. Because obviously if your heart is pumping at 120, then you've got half the time, as it were. And so that normally the ratio of systole to diastole is 1 to 2. But when it's going at 120, 150, it's nearer to 1 to 1. And so this corrects it to a measure of 60. And at 60, the normal value is a third of a second. So 1 beat per second, 60 beats per minute. Therefore, 1 to 2 ratio. So the normal flow time at a heart rate of 60 should be about a third of a second. That makes sense? Simple A. So about 330 to 350 milliseconds. And that value is inversely related to the systemic vascular resistance. So if the afterload's high, they're constricted, that gets narrower, and if it's dilated, it gets wider. And lots of reasons for vasodilation. The patient can be septic, or you put an epidural in, or they're exercising, or they're pregnant, for example, and vice versa. When they're vasoconstricted, it could be because they're hypovolemic and or cold, and or you're using too much metaraminol, norepinephrine, whatever, or there's an obstruction in the circulation. So the blood can't get through to the left ventricle. And so it's pumping and thinks, hey, I'm hypovolemic. It's not actually hypovolemic, it's just that there's an obstruction to flow, but it thinks, the left heart thinks I'm not getting enough blood. And so it acts as if it's hypovolemic. And so you get that narrow signal. And so clearly we'll talk about how you differentiate these different things in a second, but immediately you can think this patient's vasoconstricted for some reason, or this patient's vasodilated for some reason. Doesn't tell you what, you've got to work that out, then you can try things. Medicine's cookery, isn't it? You try something, and if it works, great. And you think, do I need to give a bit more, sherry in the trifle or whatever? And you try it again. And if you think, too much, or we go to something else. So medicine's like that, isn't it? The beauty of it, the art. I mentioned the peak velocities and marker of contractility, and I mentioned earlier that as a fact of life, our heart is less contractile as we get older. So there's a normal range which is dictated by the age of the patient. So in general, a normal velocity when you're 20, young, fit, active, is about 90 to 120 centimeters per second. And actually, interestingly, through, again, this is my study through childhood, that is actually fairly fixed from neonate to a young adult. There's lots of theories behind that, that stays fairly fixed until you get to an adulthood, but then it goes down by about 1% per year of adult life. Right, mate. But as I said, our aorta does dilate partially to help compensate. So by the time we get to 70, the normal range is about 50 to 70. So if you look at the patient's age, you'll know that approximately, at least, if not definitely. That should be where the normal range sits. And so if it's a hyperdynamic circulation, the left ventricle is pumping really hard, you know, septic, for example, or you're giving them an inotrope, then it's much higher than you expect for that person's age. Likewise, if it's much lower than you'd expect, it's a hypodynamic circulation. So, happy so far? Any questions?
This one, what I've noticed, different countries, different things, but in children, and talking about adolescents, that are a lot of them are obese. I've noticed that the peak velocity is way lower than we once expected. Yes, and I was wondering if there's any study.
I've not heard that, so it's really interesting.
I've seen it in the US a lot. I mean, a lot. It's a couple of weeks. And this, they're 16 years old and they have a peak velocity of less than 80. And they're obese. I mean, they're all obese. They don't move big. They don't walk even stairs. So I was wondering if there's.
I did not really, but really interesting. I've never, I'm not looked.
Well, I mean, I just noticed it. Yeah, I'm saying that there's a pattern or something, but it's very nice to me. I saw that in Mexico as well, and you know, all the children are always obese, and it's a thing that I was wondering if there's any study done.
Fascinating. I'll actually look that up because I'm not obviously Googled or did that, but yeah, interesting. So are they sitting time bomb these people? Yes, it's I think probably the answer. Interesting. Do you guys know about the obesity paradox? Well, it's very just digressing on that. Interestingly, absolutely with chronic, time, it's bad to be fat. You know, you get obviously apart from all the lack of fitness, your heart, strokes, knees, everything goes, hips, etc. Diabetes, etc. But interestingly, in the short term, if you're acutely ill, it pays to be fat. So the outcomes are better for like sepsis, heart failure, cancer, because you've got blubber. So you start wasting away, if you've got more blubber to waste away, you last longer. So it's interesting, it's obviously a paradox, but certainly it's not good in the long term to be obese. I'll run a bit harder tomorrow. Okay, so we were talking about changes. So you can see this is a patient who is hypovolemic and got a bit of fluid, and you can see that narrow waveform widens. And the predominant change is in the corrected flow time. So you've gone from a constricted circulation because the body's trying to react to the hypovolemia, and giving the fluid, it opens out. So that's a simple example of preload contractility. As I said, the major effect you can see before and after an inotrope. Oh, the peak velocity shot up. But again, it's a nice marker of contractility and left ventricular dysfunction, which is improved. And the dilator has an intermediate effect. So you're reducing the resistance against which the heart has to pump, and so it can pump stronger and for a longer period of time. So the peak goes up and it gets wider. And so you're improving both the corrected flow time and the peak velocity. And when you're vasoconstricted, it's the opposite. So summarizing, those are the predominant changes you see. So when you drop the preload, they're bleeding, for example, you see it getting narrower and narrower. And when you go from a empty state and fill them up, it gets wider. Clearly, if you overdo your fluid, then you start knocking off the heart and the peak velocity drops. So it's a good idea. We'll talk about fluid challenges later, but essentially preload predominantly affect the width of corrected flow time. Inotropy, positive or negative, predominantly affects the height, and changes in afterload have an immediate effect. Again, years ago, if anyone's interested, I can give them a PDF. In my rash young investigator days, we were giving each other, there's about 5, 6 of us who gave each other a whole variety of different drugs. Beta blockers, vasoconstrictors, vasodilators, inotropes. And we also got the blood transfusion people to take a litre of plasma off. So we had hypovolemia and we did passive tilt to accentuate it. So they kept the plasma as a thanks for the plasma and whatever. Well, just kind of variety, and it was great. Actually, it taught me a lot of physiology, and pharmacology. And you suddenly think, oh gosh, we're doing that to patients. Some of the things that we do, and you're thinking, oh gosh. And I'll give you a few examples of. Big fact here. Any volunteers? Has anyone had? I'll give you an example. Has anyone ever had dobutamine? Weird drug. How much would, if you were going to give it to like a healthy volunteer, what sort of dose would you start with? A healthy person. Because normally we start, 2.5, 5 mics per kilo per minute? Well, I asked, the boss who was working with David Bennett, remember, so you can't do part of it, but he'd had it himself years ago. He said, I'd go lower. And I said, why is that? And you'll find out. So we had a sort of dose response. We started at 1.25, then 2.5, and then 5. And literally, at 1.25, you could see your scalp tingling, like increased blood flow to your scalp. And you felt your heart doing that. And then at 2.5, it was more tingly. And at 5, literally, it felt your heart was going to sort of coming up your chest. Just doing a really sort of itchy forehead. It was quite interesting, and yet we backed into the patient. It benefits. Trust me, I'm the doctor. I think have the drug. But it's actually quite interesting. And thankfully, I had a slow heart rate, so I didn't get the vasoconstrictors because you get sort of bradycardia. And so at the time, my heart rate was about 35, 40. So that got me out there. But one of my friends, he had intense bladder spasm. Just sit there till the end of the experiment. The things we do to our patient. Okay. Putting the probe in, it's important that the probe is placed correctly. So these are my sort of simple rules. Put some gel on the tip of the probe, KY or whatever, and then that helps give a good initial contact medium. As I mentioned earlier, the esophagus secretes mucus that helps maintain that. But in the first instance, the gel slide in and also helps get a good contact. Again, when you're putting it in, don't ram it in. I normally use a sort of screwing action in the middle line, and it just slides in, So, again, if you're forcing it, then you're likely to cause harm to common sense. It's like anything. And it's like with NG tubes. If you feel a lot of resistance, not a good idea to carry on pushing. So it's the same here. As I mentioned before, there are 3 marks on the probe. 35, 40, 45 centimeters from the teeth. So your average person, it's around the 40 mark, people take. And so you might need to come up a bit if they're short and go in a bit further if they're tall. But basically, you get it to that approximate depth and then move up and down and side to side, because if you remember the aorta behind the esophagus, until it's focused on the aorta. I'll show you some signals there. So basically, then you tweak it until a combination of both the best sound you can get, so the highest pitch you can get on the loudspeaker, and the sharpest signal you can see on the monitor. And I'll show you that in a sec. So you want a really nice crisp waveform, like here, with black inside and that's sort of what's called a narrow spectral envelope. And that means most of the blood is traveling at more or less the same velocity. And if you remember what I said right at the beginning, if the probe is directed across the center of the blood vessel, the aorta, blood is traveling more or less at the same speed. So you know that you're focused across the center rather than the edge of the aorta if you get that nice crisp waveform with a black inside. Because essentially, there's no blood, like if you draw a line up here, there's no blood anywhere here until you get right to there. So it's a nice way of knowing you're looking at the center of the vessel. And then you can set the machine to run, and then you've got this green line follower, and then your eye should verify that what the machine is measuring, we've got the arrows at the beginning, peak and end, is what you think. So your eye verifies that what the machine is measuring is accurate. Because if those little three arrows aren't aligned, then the machine is giving you different numbers. Happy? Okay. So that's the ideal. Descending thoracic aorta, that nice crisp waveform, and a nice sound on the monitor. If you're too high up, you can be picking up the pulmonary arteries. And if you're too far down, you can actually pick up the celiac axis, or even sometimes just descending abdominal aorta, you've gone below the diaphragm. So you can pick up different signals. If you're looking, again, the up means blood's flowing away from the probe. Down means it's coming towards the probe. So the ascending aorta is going, if you're too high up, you'll pick up the sloan going up towards the probe. So it looks as if it's pointing downwards. And if the probe is facing anteriorly rather than posteriorly, you hear heart sound. You see blood going through the heart valves. So the final one is if you're looking at next to the aorta is the hemizygous vein, and you get it sounds like the sea. It's quite restful these when you hear the sea. Get the seashell, we hear the sea, and it's just similar. But it's not what you want to measure. You want to measure that. Okay, again, we can talk about this in more detail. But like any device, there are pros and cons. And like any device, it behoves the operator to actually know what they're doing. So even though pulmonary artery catheters are, in inverted commas, the gold standard, they're not. They've got their own problems. And as where I'm a bit cynical about, especially non-calibrated post-control analysis, but just focusing, again, we can chat about these later, but just focusing on Doppler, I will talk about aortic regurg later. I mentioned coarctation. Clearly, if they've got, an esophageal perforation, you're not really going to put an NGQ down unless it's under direct vision or a Doppler probe. There is a need for refocusing, so that's probably the main irritation, isn't it? Sometimes it just sits there and it's fine. Sometimes you lose the signal. The patient's wrong. You have to retweak it. So that's the biggest frustration. But with experience, this is the right depth, and just tweak it. The risk actually, remarkably over the years, I think, and there was one I heard, a case of Japan where somebody had been too aggressive and caused some damage to the esophagus. But literally, thousands have used it. No one, it's not, as far as I know, the company hasn't told me at least, but I think they would have sort of said, but there's no major injury. Occasionally, like with any NG2 or whatever, you can cause sometimes a small amount of bleeding. Again, at ECH, where I used to do the Conibar going on last year, loads of hemonc patients with low platelet counts. Use it called absolute exposure. Again, it's a cryogentle. Absolutely no problem. You just gently insert it, and I think the longest I've ever kept a probe in a patient was 18 days. So, I think generally it's this, I think, a safe device, but again, common sense. So, okay, we can measure all these things, do things. I like quoting this guy, Ludwig, who was a German physiologist over 100 years ago. And he said the fundamental problems in the circulation derived from the fact that the had adequate amounts of blood to the body organs is the main purpose of the circulation. The pressures that are necessary to achieve it are of secondary importance. It's easy to measure pressure, it's much more difficult to measure flow. So our knowledge of flow is usually derivatory, as we're guessing. And that frightens me that we've got a sick patient and you don't monitor the flow and you're guessing and get it wrong a lot. Does it make a difference to the patient? Well, if it was me or a family member, well, I'd rather have a more focused, oriented, smart approach rather than guessing. I don't know how many of you read the New England. It was a horrible trial from France. 1,000 patients randomized who had shock and half the septic or cardiogenic or hypovolemic shock, the whole shock patients. And the trial was randomizing, in the first few hours to either get or not get an arterial line. And if you read the paper, they didn't get any cardiac output monitoring. And they, a minority had a central line aging. So they were managing shock patients on a blood pressure cuff. And because they didn't have the R line, and often not a central line, they would do more stats. Good lag trip, whatever. It horrified me, thinking, oh my God, nothing won't be managed like that. And yet it got done and it got in the New England Journal. So I'm getting old. But, it would, I think, behove us and help the patient to know, do they need fluid? How much? Not too much. We don't want to drown them. Do they need an inotrope or a vasopressor? And again, loads of studies show that our ability to diagnose accurately the circulation at the end of the bed in a sick patient is poor. So hopefully we'd all agree. I'll leave it at that. You don't want to too much for them. You don't want to give them too little. You don't want to overdo the vasopressor. Get the fingers and toes dropping off, and that's what we see. What we're doing to our internal organs. This is me on the all around. Infection control. You can see hand washing. Precautions around the bed. Not in the unit, the UCH. I would argue that the blood pressure alone is a poor guide, and clinical assessment isn't much better. Anyone think they're a good clinician? Anyone think they're above average? When you think about it, only half of you could be above average, the other half must be below average. But we all think when we look in the mirror, oh, I'm a good doctor, I'm a good nurse. Otherwise, you wouldn't have the confidence to do what you do. So we all delude ourselves that we know more than perhaps we do, myself included, I should add. So there's some nice studies. They're old, and this is using the PA catheter years ago. These are 2 American studies in ICU patients, and they asked clinicians to examine the patient, look at the X-ray, whatever, and estimate what you think the cardiac output would be and the filling pressure, the wedge pressure. And you can see they got it right less than half the time. And this is a British study of patients in pulmonary edema and acute heart failure in a coronary care unit. And again, on 1 in 3 occasions, they got it wrong. This is badly wrong, not just a little bit wrong. And what about that wonderful word experience? I've been doing this for 30 years, my dad, I know what's going on. In the Connor study, the medical students did as well as the consultants, or as badly as the consultants. What price experience? And having the additional information led to a change in treatment in half the cases. Doesn't mean they survive better as a result. And that's always been one of the problems, because a lot of people, for those that work in intensive care, know that some patients go there and will die regardless of what you do. But at least there was a change in management directed by additional information. The Frank Starling curve. I always ask, is Frank Starling's first name? There's a hyphen, no. It's basically, Frank was a German, Otto Frank, and Starling was Ernest Starling. He worked at UCL, where I am now, And I worked with a guy who had his older have eyes tiny when he said, touched the dementia before was smiling was here. That's him with his hair in a dog. He'd been mainly dog experience. But essentially, you can recapitulate this dying curve using the Doppler, and you can see patient hypovolemic fluid, and you can see it goes up the curve. And you know there comes a point where it's not going to improve anymore. So that means either you've adequately filled the patient, or maybe they're bleeding quicker or at the same rate that you're putting the fluid in. Thankfully, that doesn't occur too often. But again, you get a feeling as to where you are with the patient if they are bleeding out at the rate you're getting the fluid. But generally, it's a nice way of seeing if A, the patient's hypovolemic, and B, how they respond to fluid challenges. And there are loads of studies, clinical studies, in the literature that actually doing randomized trials. This is made all in the perioperative, either started in the operating theatre or immediately post-operative. It's just try and optimize fluid. I think generally people are better now than they were like 20, 30 years ago. It was a nice study, I don't know if it got published, but they were certainly talking about it. That was from St George's, where they looked at who did, from an anaesthetic point of view, hip fracture surgery, where we know there's a high complication rate. And interestingly, the ones with the best outcomes were the registrars, because the SHOs were too scared to give fluid and the consultants were too scared to give fluid. And so a lot of the time they were undercooked the patients, and the registrars were a bit more, I'll go and post fluids with you. And they had the best results. I don't think it ever got published because consultants felt a bit too uneasy about showing their inadequacies. But I thought that's it, I think. Anyway, there are a whole variety of studies. I'll pick just the one. This is probably the largest one. It's a multi-center study from Spain with about over 400 patients. And again, using fluid challenges to look for a stroke volume rise of 10% or more to optimize the stroke volume. And then depending on the hemodynamics, if they still had a low cardiac output despite the filling, you could add in an inotrope. And if they were vasodilated, you could add in a vasopressor. What did they find? Basically, there was a halving in moderate and severe complication rate. And obviously, you get out of hospital quicker. So again, it's just a simple thing. Just monitoring the fluid in a high-risk patient, you can hopefully ease the passage of these patients post-operatively. So, in summary, I think it's a nice, simple device. There is a learning curve. It's pretty quick. There's a nice study from France years ago where literally, I think, certainly within 20 patients, you'll be actually proficient. So you've got to go up that curve, like anything. You're taught, and again, at UCH, the nurses were very good at teaching the next cohort, and so the medics. So you can use it. I think it's user friendly for both doctors and nurses. As I said, it showed my inadequacies up time and again, and it all met my clinical judgment. Finish there. Any questions or comments or thoughts for those who've used it before? Please.
Now that we are using a lot more minimal access and the incidence of space, verticals, it's a lot less.
Would you say that blanket usage of this device is?
I think probably, yeah. I think you can be selected because you can pick either the patients who's going to have a tricky operation, where they're going to lose a lot of blood predicted, or you don't trust the surgeon. Right after the good take, or the patient themselves are high risk. They've got lousy heart, lousy lungs, whatever. So you target the patient. You don't put an arterial line in every patient having minimally invasive surgery. So again, you're selecting patients that worry you a bit more. And so I would argue, again, be selective. It's not every patient needs one. And if you look, obviously there's lots of anesthetic outcomes data where it's the higher risk patients, the ASA 3s and 4s who are much more likely to have a problem. But the ASA 1s and 2s, if they had some pteranodoplasty, again, the risk of them having, obviously things break, again, poor perfusion means your anastomosis breaks down and the infection increases. Obviously, bleeding risk if you're, worried about if, if they've done the knots up properly, etc. So all of these sorts of patients. So again, you've got that expertise to know in whom I'm a bit more worried about that patient. And, that's what pre-assessment clinics do, don't they? Yes. So, I wouldn't personally recommend it. I'm sure Deltex would love it. But, HS, are the ones that it's sort of cost-benefit equation, isn't it? You want to get the sort of sweet spot where you're using the pros, which gives the benefit in terms of reducing hospital stay, reducing complications, without, it's like changing every bed in the hospital into an ICU bed. You don't want that.
The point I was trying to make was gone on the days that we made as if he's done infuseless incision or literally every gynecology, toilet medicine, welfare GI, all that it does happen anymore. Yes. So I used to use Doppler of Deltex for all of my elective work.
Yeah. But you still will the laparotomies, the kneelers.
So there are two theatres in our suite, which will be the emergency theatre and the trauma. These
Yes. Yeah. And we know that they do badly, although, there's a high risk of them doing badly, I should say. Yeah, no, absolutely. So I think it's, it's sort of, as I said, patient selection. And I made the point, I think we have got better at anaesthetic management, and laparoscopy, I'm sure, has obviously contributed. As you say, you don't need that with all the trauma and inflammation that causes.
And the surgery making the unintentional,
Slip-ups. Yeah, absolutely. And, I think even in laparoscopy, again, sometimes patients, especially if they've got poor cardiac reserve, can be compromised. When you suddenly, cross over venous return and put the head down, etc. So I think, again, it's that high risk patient that I think merits a bit more monitoring. I remember in the old days, there's a guy who, when I was doing sort of research on it at St. George's, actually, in cardiac anesthesia, his dad used to be a cardiac anaesthetist. And in that postload, he just had a blood pressure cuff, and they didn't have signatory or R lines. It was just you manage cardiac surgery on a blood pressure cuff. I think it's a lot better now, hopefully.